Welcome to the Who, What, Why podcast. I'm your host, Jeff Schechtman. In a way, it seems that as doctors and scientists know more about the novel coronavirus, we seem to know less. Giant leaps are being made in the treatment of the disease, yet current events have raised a whole new series of questions. How long is it contagious? What's the best treatment? Can spreaders of the disease be completely asymptomatic? Is there a cure? Why do certain places become clusters? And are the percentage of deaths dropping, even while the cases continue to rise in so many places? And why are we still debating the proven efficacy of masks? 7 months since the national lockdown, a whole new wave of questions are emerging, and a slew of misinformation, particularly from the White House, is rampant. For answers, we're going to turn to Dr. Robert Wachter. He is the professor and chair of the Department of Medicine at the University of California, San Francisco. He is the author of over 300 articles and 6 books, and coined the term hospitalist, and is often considered the father of the hospitalist field. He's the past president of the Society of Hospital Medicine and past chair of the American Board of Internal Medicine. Several years ago, he was ranked as one of the most influential physician executives in the United States and has served on the healthcare advisory boards of several companies. It is my pleasure to welcome Dr. Robert Wachter to the Who, What, Why podcast. Doctor, thanks so much for joining us.
It's a great pleasure. Thanks for having me.
Well, it's good to have you here. In some ways, with respect to people understanding what's going on and the realities of the virus, it seems that we're going backwards in some ways. Talk about that.
Well, we're certainly seeing a new surge mostly in the Midwest, and that's disappointing because, first of all, a lot of people are going to be harmed and die from it. And second of all, we're now 7 or 8 months into it, so we should know better. The first surge in the Northeast in March and April in some ways was more forgivable because the disease was spreading before we had widespread testing. We really didn't understand it very well. The second one during the summer, June, July, was more disappointing in that we did know what to do, but for many reasons, largely political. People were not doing the right things. They were not being given the right message. And this one now, for this to be happening now 7, 8 months into it, is really disheartening because one of the things that we've learned is this is a nasty virus. Many people were going to die from it, even under the best of circumstances. But we could probably be preventing about 80% of the cases that we're seeing if everybody just did the right thing.
And yet we're being told at the highest levels that there's nothing to worry about, that there's a cure, that we don't need to worry about masks. From a medical point of view, talk about how you and your colleagues react to that.
Well, it just feels like we're fighting misinformation up a hill all the time. And this is not just an academic issue for us or one of sort of empathy for other people. We have all of that, but we're also on the front lines. We're going in the hospital taking care of people. And it's just incredibly sad to see people hospitalized, struggling for air, and some of them dying for a disease that could have been prevented in many of the cases. The amount of bad information people have gotten from the federal government is extraordinary. We know now that masks work amazingly well. Not perfect, but if everybody wore a mask, we could probably prevent 70 or 80% of the cases. The combination of just the simple recommendations, it feels boring to say this, but it really, it's not fancy. It's not like you have to take chemotherapy. It's masks, it's distancing, it's avoiding large crowds, it's avoiding indoor unventilated spaces if you can. Those would be preventing probably 4 out of 5 of the cases. And to hear messaging that is either a hoax or we have the cure or those things don't work or, you shouldn't be too worried about it. I mean, when I read, don't worry about it, it's like, you got to be kidding me. 220,000 Americans, 1 million people across the globe have died of this. Yes, you should be worried about it.
In all of your work with diseases and situations like this, have you ever seen a situation that's analogous to this, where from a public health perspective, people seem to be doing exactly the opposite of what they need to do?
Nothing is quite like this because we've never, I'm not old enough to have been alive in 1918 for the last worldwide pandemic. But I mean, there's always misinformation and I mean, people don't always do the right thing. People smoke, people drive too fast, people don't wear seatbelts. This is not an unknown problem. In this particular world of prevention in healthcare, we see people not taking vaccines and then kids getting sick. We've seen poor federal responses to national tragedies. The most vivid, I live in San Francisco, and the most vivid is AIDS, where, in the early years of the AIDS epidemic, which had a somewhat different flavor in that it had 100% mortality. Everybody who got it died, but it wasn't, not everybody was vulnerable to it. So it was tending to strike largely the gay population early on. The federal government paid no attention to HIV. The President Reagan did not mention the word AIDS in a speech until 6 years into the epidemic. So having a poor and politicized federal response is not new. Having people sometimes not do what they should do in order to protect themselves or protect others is not new. But I don't think we've ever seen all of it combined in something that looks like this. And I think particularly with this federal government, we've never seen anything quite like this. The amount of misinformation, the pandemics have been gamed out for years. There have been people who do this for a living, like try to figure out worst case scenarios, where it's going to spread, how should we react. And in all of those simulations of what the pandemic would look like, there was never a simulation that anybody did that said the President of the United States is going to be the major source of misinformation, as he has been in this case. It was just like, why would you game that out? That's not going to happen. It may happen that people are not going to wear masks. It may happen that, that people don't do the right thing in this way or the other way. But the idea that the federal government would be the major source of misinformation was not something that was thought to be a realistic possibility.
In the early stages of the pandemic, particularly on the East Coast, there were so many reports of the deaths that were taking place, of bodies piled up literally in trucks behind hospitals. A lot of that scared people. We're not seeing that kind of coverage today. Has that enabled people to let their guard down, do you think?
Yeah, absolutely. I think the early days, you saw the morgues outside the hospital and the body bags, and I think that scared some people straight. Now the coverage is a little bit bloodless. I mean, it's numbers. And I think we've become inured to the numbers. If you thought about this in March, if you had said in October, we're still going to be having 700 or 800 people a day dying of this thing, I think people would have been flabbergasted. People would have been shocked. And now it's become almost baked in. It's like, okay, that's all right. Maybe if it gets to 1,000, we'll notice. That's 700 or 800 of our countrymen dying every single day. Think about each one of them and their lives and their families. And it's an extraordinary tragedy. But unfortunately, this is, to some extent, human nature. People become inured to the statistics over time. They want to get their lives back. They want to move on. Of course, we all do, but the virus hasn't forgotten us, and there's nothing about the virus that has changed in a meaningful way. It's still the same, and it is still as deadly as it was 8 or 9 months ago. And there's nothing about us that's changed, except for the 5 to 10% of us around the country that have already been infected. The 90% of us that are still vulnerable, we're every bit as vulnerable. So, if you let your guard down and the virus happens to be in your community, the dynamics of you getting infected and getting ill and dying are pretty much the same as they were. There have been some advances in treatments. This is not new for us anymore as physicians. We know how to take care of the disease in ways that we didn't. There are things that were very surprising in the beginning that are less surprising now. Some of the therapies are moderately effective. The highest risk people, I think, are being sheltered and being more careful. So we're not seeing the kinds of outbreaks in nursing homes to the same extent that we were seeing in March and April. So the death rate is down a little bit, but it is still a pretty deadly disease. And, if you're sick enough to end up in the hospital and certainly end up in the ICU, you have reasonable odds of not making it out of there alive.
What have we learned in terms of, and there have been several reports from the World Health Organization and other groups about the transmission of the disease today? We've learned a lot about it being more airborne than we originally thought.
Yeah, the terminology gets very confusing, and it actually just is confusing because it's airborne. There are different ways of it being airborne. What's been clear all along is that droplets, meaning I sneezed on you or I coughed on you or I was speaking loudly and I had virus in the back of my throat and it just flew into your eyes, nose, or throat. That's the main way that people get it, which is why if both of us are wearing masks, the chances of that happening go down considerably. If we're more than 6 feet apart, the goblets tend not to go that far, certainly not in a high enough volume that they're going to get people infected. We also know that aerosol transmission is possible. It's less common, but it can happen. So what aerosol transmission means, as opposed to droplet, is rather than me directly spraying you with virus, I have virus. By the way, I don't, I think. But a person has virus. They cough or breathe, and there's now a mist of virus in the air. None of us can see it. The person leaves the room. I enter that space, and now I breathe in and I can get it. If that was common, we would be seeing a whole lot more outbreaks than we've seen. But we know that it can happen. It can happen particularly in closed indoor spaces where there's poor ventilation. And so you want to avoid those things. Again, if the person who had COVID was wearing a mask, that wouldn't happen because they wouldn't be leaving this dust trail of virus in the air for the next person to get. But we know that the things that we're more confident about than we were in March are that it's mostly this droplet. It can be aerosol in unusual cases. We know that outdoors is far better than indoors, mainly just because of the dispersion, but it's not 100% protective, because if you just think about it, if I'm a foot away from you and I cough or sneeze on you, the fact that you're outdoors is not all that protective. But it's better, ventilation makes a big difference. So we know all of those things. The surface transmission is not impossible, but far less common than we were worried about. So we know a lot more than we knew about how it's transmitted, but it doesn't really change the facts on the ground that distancing, masking, avoiding large crowds, cleaning your hands, if we all did that, we would markedly decrease the rate of infection.
Talk a little bit about the contagion aspect of people that are at various stages of the disease. Certainly what we have been seeing the past week from the president, what we've seen from the senator from Utah who showed up at a hearing today after testing positive just a few days ago. Yeah,
it's all pretty shocking. What we know is that you are contagious. If you have COVID, you are contagious before you feel sick. And in fact, 30 or 40% of people will never feel sick, and yet they are contagious. So the timeline is you get the disease, you get the virus from somewhere, somebody. 3-4 days later, you now have enough virus replicating in the back of your mouth and your nose that you are contagious, but you feel fine. That turns out to be one of the virus's real superpowers. But we didn't know that in the beginning. In the beginning, it was all this stuff with temperature checking and symptom inventories. That's fine, but it certainly doesn't. It can't be your only defense, because most people begin to be contagious before they feel sick, and some of them will never feel sick. If you're going to go on and begin to feel sick, it's probably going to happen a day or two later. And then we know that the average person is no longer contagious about 10 days later. But that's a difficult thing to be sure of in any individual person. There's no easily available test that looks for live virus that can tell us with 100% certainty that 10 days later is the absolute cutoff and you're fine. And in fact, we have seen cases where that time has been longer than 10 days. People have been contagious for longer, particularly if you had a very severe case severe enough that you were hospitalized, and also particularly if your own immune system is not as good. And we think that's also if you've gotten a drug to suppress your immune system like prednisone. So in the president's case, after 10 days out, he is probably no longer contagious, but not definitively, because he had a severe case, at least at first, and he was on steroids. And the safe and prudent thing to do if you've had COVID is to continue to wear a mask and try to stay away from people for at least another week or two after the 10 days is over. And just the message that it sends for the senator to come in without wearing a mask is it's shocking.
And what about these drugs that we're hearing about and we're being told by the president that it's a cure?
Yeah. He got 3 drugs, and he's convinced that one of them was decisive, and he had after his initially scary course, he had a fairly benign course. He's getting to the point where he's almost out of the woods. Not quite yet, but another day or two, if he's fine, he's probably going to be fine. So 2 of the drugs are pretty standard now. If you were sick and came to my hospital, we would give you the antiviral medicine remdesivir, and if you were very sick, we would give you the steroid medicine dexamethasone. And they've been shown to be effective. Dexamethasone lowers the death rate. Remdesivir shortens the length of illness, but hasn't quite been shown to lower the death rates. But reasonable to give both of those. The third medicine is this monoclonal antibody. He got a combo of 2 of them, and that's a medicine that's designed to give you an engineered antibody instead of what a vaccine will ultimately do, which is stimulate your own body to develop its own antibodies. It makes a lot of theoretical sense. The early and very preliminary studies in a small number of patients are promising, but not definitive. It's not generally available. You couldn't get it. I couldn't get it. I couldn't give it to one of my patients today, but he got it because he's the president. That raises its own ethical questions, but that's another issue. And he did well. So whether it was one of the medicines, 2 or 3, or just luck will never be known. He had, when he first got diagnosed, he probably had a 5% chance of dying. So he had a 95% chance of doing fine. Might have gotten sicker, but not dying of the illness. If he had gone into a controlled trial, we're doing a trial at UCSF of the monoclonal antibodies, he would have had a 50-50 chance of getting monoclonal antibodies or placebo. So if he'd gotten placebo, he had a 19 out of 20 chance of doing fine. And I don't know if he'd be out there doing his infomercials about this miracle drug called placebo, but here he is. So it's not, he doesn't approach the world in a normally scientific way. There's no way of knowing if any of the medicines were what, quote, cured him. By the way, that's not the right word, but he certainly did well. And certainly the evidence that would support a claim that particular medicine, the monoclonal antibodies, was the thing that made him better is scanty and a little bit magical.
And monoclonal antibodies has been something that's been used for a while as a cancer drug.
Yeah, and actually it's a technique that's been around for a while and is quite helpful in certain cancers and in certain other inflammatory diseases or infections. So it's not a new thing, but it's not made it through gone through all of its paces in terms of the testing it needs to have for COVID to be certain that it works. My guess is that it's good. My guess is that the preliminary studies are pretty promising and don't seem to be showing significant side effects. And we're just waiting for larger studies to prove for sure, statistically sure, that it can't just be chance, that the drugs really are effective. And then, but if I was a betting man, I would say I think they probably are. I think they're going to turn out to be a useful part of our armamentarium. I don't think they are game changers, partly because I don't think they're going to be that effective, and partly because there's a lot of complexity in their use. And I'll just run through a few of them very quickly. First is we don't know for sure, like, which people should get it. Giving it to a 74-year-old overweight man who had a pretty high risk, that probably is a reasonable use case. But, which patients are going to get it, which patients are not, is a pretty tricky call. The second is it's a pretty hard drug to manufacture. So even though he's out there saying everybody can get it for free, the companies say the best we can do is produce maybe 50,000 or 100,000 doses in the next few months. That's how many people are infected a day in the United States. So there'll be a wildly inadequate supply, even if it turns out it's useful. He says it's going to be available for free. I think it's going to cost a few $1,000s a dose. So somebody's going to have to pay that difference if, in fact, it's going to be available for free. I think nobody really believes that. So it's not a slam dunk that this medicine is going to come out, be demonstrated to be effective, and then become widely available in a way that's really going to change the overall trajectory of the illness. But I do think that a couple of months from now, if you were diagnosed with COVID and you had a very high predicted mortality, let's say you were 75 years old and you had diabetes and obesity, and so your chances of dying from it are in the 5 to 10% range, that might be someone who, as we try to ration the medication, because it will have to be rationed, it won't be enough, that might be someone in whom giving it the benefits of it outweigh the risks.
Have we learned more about what comorbidities pose a higher risk? Is it just being 74 years old? Is it being overweight? Have we learned more about that?
Yeah. Well, I don't, as I get older, I don't consider age to be a comorbidity. I'll just consider it a fact of life. So the comorbidities are the other things, the sort of other illnesses that you have that add to the risk. So clearly age is the most important risk factor. So if, 80-year-olds have predicted mortality rates in the 20% range, and everybody over 60, it gets into maybe the 5% range, whereas if you take all comers, it's about 0.6%. So certainly young people have a far lower rate of dying and getting very sick than older people. So that's the first thing that's become very clear is the age is a biggest risk factor. But layered on top of that, the other things are somewhat predictable. Diabetes, pre-existing heart disease, pre-existing lung disease like emphysema or asthma, even high blood pressure raise your risk. I think the big surprise here is obesity, where for a lot of other diseases, if you're obese, the chances of you doing worse are a little bit higher. The degree to which obesity markedly raises the risk of a bad outcome is pretty striking for COVID, and nobody really understands why. And for many other diseases, it's just your body is a little bit more taxed in terms of the ease of breathing. That's why it's harder for you to get around. Getting people mobilized and walking around early is a good thing. But it seems like the risk that obesity confers here, which is at least 3 or 4 times that if you take the same age group, 3 or 4 times higher than it would be if you weren't obese. That's partly why the president's risk was high, because he's 74 and he does fall into the moderate obesity category. Nobody really knows why COVID plus obesity is so risky. It's, people are thinking that it has something to do with actually the fat tissue and the way it deals with the virus. But I think right now it's mostly hand waving, but it's very real.
Mm-hmm. When we look at these clusters, like what we've seen happen at the White House, what do we learn from those experiences that we can relate to the general population and learn from?
Well, it is yet another superpower of this infection, this propensity to cause super spreader events. And if you look at it sort of from a physics standpoint, it's another thing that's a little bit unusual about the coronavirus. For many other infections, there is a certain, everybody's familiar now with this term R naught, there's a certain number that says the average person who has the thing will give it to this many other people. And for COVID, that number, without any distancing or masking, that number is about 2.5. So the average person that gets COVID over the next week or so, when they're infectious, will give it to 2.5 other people. If you wear masks and do distancing, that number falls often below 1, which is when the disease starts dying out. What's weird, another kind of oddity of COVID, is that that's not a consistent number. It seems like there are some people where their number, rather than being 2.5, is probably less than 1 just on its own, forgetting even about the masks and the distancing. For some reason, they don't spread it very much. And for other people, the number is far higher than that. And what it is about those people, whether it's the anatomy of their face and their mouth and their nose, whether it's that they tend to talk louder, or they tend to talk a lot, or some other factor we have not figured out, is basically unknown at this point. But we do know that if you happen to be that person, and there's no test that will tell us that, it doesn't seem to be highly related to the amount of virus you have in you, which you might expect, but doesn't seem to be a perfect correlation. So unfortunately, these people don't have labels. We don't know who they are. But if you happen to be one of them and you happen to be in a setting where there's particularly indoors with a lot of people and not very much ventilation, there's a decent chance you will infect not 2.5 other people, but 10 or 20 or 30. And the problem, of course, then is those people now are infectious and they will go out and infect others. And before you know it, you have a super spreader event and you have exponential growth. So it appears that that's what happened in the Rose Garden, and whether most of the transmission was outside, which would be unusual. But if you looked at the videos, you saw a lot of people hugging and kissing and at very close quarters with very little masking. Or, as we suspect, some of it was outside, but a lot of it was when they went inside for the reception. Hard to know. We don't know who the person was in terms of patient zero, but that's how this goes. And we've seen now a number of those events that have happened in business meetings and in church choirs and all sorts of different circumstances. But they tend to share the fact that people are not wearing masks, people are at close quarters with each other, there's poor ventilation, and then there's bad luck.
And finally, are you hearing from patients some of this misinformation repeated back to you and your colleagues, and having to deal with that as another aspect of this right now?
Some, but it's very regional. So, I live in San Francisco, where by and large, I think people have taken this thing seriously from the beginning. The messaging from our local health leaders and corporate leaders and political leaders has been consistent and comports with the science. And the proof is in the pudding. We have had, since this thing started, we've had 125 deaths in the city of San Francisco. New York is at 25,000. It's a remarkably low death count in the city. And if you extrapolated, and by far the lowest death rate per capita of any of the largest cities, 20 largest cities in the United States, if you extrapolated our per capita death rate to the entire country, rather than 220,000 people dead, we'd have about 40,000. So we would have saved over 150,000 lives. So I feel pretty lucky to be here, because I don't hear that too much from my patients and from my friends and family. People generally get it and understand the science. They're trying to follow it. Unfortunately, that's not true in different parts of the country, and some of it has to do with sort of the libertarian, more libertarian-leaning political philosophy. Some of it has to do with the misinformation people have got from leaders. But unfortunately, we talk about the risk factors for bad things with being age and comorbidities. If you look at it, probably the biggest risk factor is whether you believe the science and you're paying attention to it in your daily activities. And some of that has to do with what individuals do, but a lot of that has to do with the messages they're hearing from their leaders.
Dr. Robert Wachter, I thank you so much for spending time with us here on the Who, What, Why podcast.
My pleasure. It was a great pleasure.
Thank you. And thank you for listening and for joining us here on Radio Who, What, Why. I hope you join us next week for another Radio Who, What, Why podcast. I'm Jeff Sheckman. If you like this podcast, please feel free to share and help others find it by rating and reviewing it on iTunes. You can also support this podcast and all the work we do by going to whowhatwhy.org/donate.